We move on to the very interesting topic of blowout fractures and flap tears. Again, Dr. Murli is not here, but his recorded talk is here, so we will have that.
Dr. Pradeep Sharma sir for having invited me for this wonderful meeting. I'll be talking on blowout fractures and flap tears.
Volume बढ़ा दो.
So as we all know, pediatric orbital trauma is a diverse clinical condition with an age-specific clinical presentation. So there are many challenges in the management of pediatric blowout fracture. The treatment of adult blowout fractures is fairly standardized, but in children there is paucity of literature and less consensus as to the management. Children are not young adults. The differences is because of difference in extent of facial growth and development, the extent of paranasal sinus pneumatization, dentition, and the structure of bone and soft tissues is not the same as in adults. In children, the skull to face ratio is 8:1. Note the frontal prominence in children. So the incidence of orbital roof fracture and forehead fractures is more common than blowout fractures in children. In adult, this disparity becomes 2.5:1. In addition, many of the sinuses which act as shock absorber protecting the brain and eye from injury are not pneumatized in children. So you would not get a blowout fracture of the orbital floor in children as young as 8 years of age because the maxillary sinus is not pneumatized. So blowout fractures in children are typically a trapdoor fracture. That is, the displaced fragment would spring back to its original position, trapping prolapsed orbital tissue. So in adult orbital fracture, you can have a number of orbital signs like periorbital edema and ecchymosis. In children, you get typically a white-eyed blowout fracture. In children, in addition, you can have nausea, vomiting, bradycardia because of oculocardiac reflex, in addition to limitation induction. This article by Burr et al. Is very comprehensive and deals extensively with orbital fracture in children. In this series, the etiology of orbital blowout fracture was mainly a road traffic accident or a fall and or injury during sports. And floor fracture was the most common fracture in this case series, affecting 33 out of 37 children. So this patient sustained injury by bumping on a flower pot. His mother noticed this face turn and got him over for a routine eye exam. Note that the only sign in this child, it was a 1-day-old injury, the only sign in this child is a right eye depression restriction and abduction. So there you go. This is a right eye depression restriction and abduction. We got a CT scan done of the orbit and it shows a teardrop sign with entrapment of the inferior rectus. Note that there is no bony displacement. Patient presented fairly early. The surgery was also done fairly early. So we managed to restore anatomical continuity of the inferior rectus and achieved resolution of the face turn. So this patient had a fall from the staircase 1 day back. Note that the only sign in this child, there's hardly any orbital swelling. The only sign in this child is a right eye depression restriction. So it's that difficult to get this clinical sign, but you need to carefully watch. See, note the right eye depression restriction. So this patient also had a similar clinical picture on CT scan. The surgery should be done as early as possible within 7 days for the best outcome, because late surgical correction is associated with ischemic injury to the prolapsed orbital muscles, resulting in persistent diplopia. For non-entrapped orbital fractures, the surgical indications are same as in adults. The presence of a significant enophthalmos globe, malposition of fracture size, more than 50% of the wall size would be an indication for surgery. In adults, you may wait for a couple of weeks for the edema to settle down, but in children, it is as early as possible. We prefer using a Prolene mesh for this. So for orbital roof fracture, the most common indication for surgery would be a bony fragment that would impinge on the superior rectus, causing motility restriction. Thank Dr. Vidya, our plastic surgeon, for sharing these slides with me. So note the left eye elevation restriction in this child and note the orbital roof fracture with the bony fragment impinging on the left superior rectus muscle. Can also present with a pulsating proptosis because of transmission of CSF pressure to the orbit. So this could result in a growing orbital fracture because of continued transmission of pressure. So you need to be conservative, minimal manipulation to prevent growth disturbance. Note that some of these implants can get dislodged later because of orbital bone growth. So minimal manipulation, minimally invasive surgery. So I would now come to muscle tears, flap tears in particular. So Ludwig and Brown published their landmark article in which they noted three anatomical variants. One is that a segment of muscle and tendon could be missing. The orbital layer of the muscle could be missing. The muscle that is torn, part of the muscle that is torn, a flap tear is simply a partial muscle tear. The muscle that is torn could be encased in adherent orbital fat. It could be associated with orbital fracture. An anterior attachment of the flap acts as a tether, and posterior flap position causes pseudo entrapment. So the motility restriction could either be in the direction of muscle or opposite to it. So this patient, the history is all important in diagnosis. This patient was traveling in a bullock cart, sustained injury with a hook, and developed this strabismus. So I would show the surgical video, not typically a flap tear, but again, note the pseudotendon at the insertion. We tried exploring the LR all the way behind the inferior oblique insertion, could not retrieve the muscle. So did a transposition procedure, transposed the inferior rectus, which was hooked and split into half. The superior rectus was subsequently hooked and cleaned, freed from the superior oblique attachment. We did a Hamilton's procedure in this patient, and satisfactory alignment was restored in primary. Satisfactory alignment was restored in primary position. So this patient sustained a Bulgor injury. So CT scan showed a partial injury to the muscle way behind the equator, and we had to do a transposition procedure because exploration this far back, and the patient also presented many days after injury was not possible. Typically, the inferior or the medial rectus is involved in injuries because of Bell's phenomenon when the patient squeezes his or her lid to protect himself from injury. So this patient also had a Bulgor injury. This was also a partial tear, and the injured fragment is prolapsing out. What happened in this patient was that the proximal fragment of the muscle was encased in orbital tissue. There was orbital fat collapse also. So we managed to retrieve and attach the muscle flap back to the insertion. So this is the alignment. The hypertrophy is fully corrected now. And the areas of fat collapse, we managed to either repair or close it with a Tenon's patch graft. This is very important because...
So I think this is almost the time that we have, and what Murli was showing was the inferior rectus flap tears have to be managed a little differently. They may have two flaps, the orbital and the global segment, and this orbital one sometimes may have a reverse leash effect. So if you just sacrifice it, it may work. So that is what is the lesson to be taken from the flap tears that is done. But these are very interesting cases which we have to deal with differently. I think we are short of time for that, but we will